Good morning, everyone. So I'll be talking about orbital cavernous venous malformation, and this is one of the large case studies that we have done. So orbital cavernous venous malformation happens to be a benign primary orbital tumor, specifically occurring in adults. And it happens to be the third most common diagnosis after the lymphoid tumors and orbital inflammatory syndromes. It has mostly asymptomatic until adulthood when it is diagnosed with various clinical symptoms. It is usually solitary, unilateral, and rarely associated with other vascular anomalies also. So we conducted a retrospective interventional study where 80 patients were analyzed, and they were all radiologically confirmed, and loss to follow-up were excluded. We saw that OCVM constituted to be 5.4% of all the operated orbital tumors in the study period, and the age range varied from a 3 years to a 65-year-old. So that's not just in adulthood, it happens in young age too. We saw a myriad of clinical presentations, proptosis being the commonest, diminished vision, palpable mass. Disc edema was also present in certain cases along with choroidal folds. Strabismus and ptosis were also common findings. Radiologically, on CT scan, we saw that the tumor was well circumscribed, hyperdense, with bony remodeling due to the chronicity, with mild contrast enhancement. MRI showed a heterogeneous mass, hypointense, and hyperintense. What's most important was the flow void. That is the diagnostic. The variable presentations were the mass was intraconal in 66%, that was commonest, but we also saw extraconal extension, extraconal mass overall, diffuse presentation, a very rare involvement of the muscle and the optic nerve too. So we had multiple interventions, that is ranging from lateral orbitotomy, anterior orbitotomy, and transconjunctival orbitotomy. Here is a video showing the lateral orbitotomy, wherein after the subauricularis dissection, periosteum is reached and it is elevated. After elevating the periosteum, sometimes we have to go ahead with the bone cut. Here, a bone cut was performed for good visualization of the tumor, and cryo-assisted extraction of the tumor was performed. Similarly, cosmetically, we had to take care of the cosmetic aspects of the patients, and we did transconjunctival approach, where the inferior fornix is approached, and after periosteal incision and dissection, again, it was visualized well, and cryo-assisted tumor delivery was performed. So transient complications were seen, that is ptosis in few cases, ocular motility restriction, visual loss, and diplopia. However, at a mean follow-up of 12 years, all the patients were functionally absolutely normal. So these are the few cases where we followed the transconjunctival approach for keeping the cosmetic part in mind. And we had complete cosmetic outcome in all our patients. So in conclusion, I would say that we know that it's a benign vascular tumor. It is seen in the middle age group, but we saw a correlation of 3 years to 65 years. And it presents mostly as proptosis, as 75% of our cases, and a well-circumscribed intraconal mass must not be missed. And radiological confirmation is mandatory because the differential diagnoses are many. And meticulous planning of surgery, especially by transconjunctival inferior fornicial approach, which we did in 22.5% cases, it leads to minimal complications and gratifying outcome, as 100% cosmesis was reached in our patients. Thank you. These are my references.
That was a good presentation, Dr. Rolika. How many cases did you study?
Ma'am, 80 patients.
80 patients.
Yes.
And follow-up was still?
12.5 years was the mean, plus minus 1.8.
Yeah. What was the differential diagnosis that you looked into?
Ma'am, the differential diagnosis ranged from vascular tumors to even fibrous tumors. We had solitary fibrous tumors and benign fibroblastic hyperplasia. We had cavernous malformations, even the vascular malformations. So it was very important for us to do an MRI and take the radiologist's opinion. So our opinions are mostly taken by a neuroradiologist who confirms the flow void. So the flow void is the indication which clarifies and confirms it.
What was the size of the largest tumor?
So size of the largest tumor. So we have not really kept the size in mind because radiologically when we do the sections, so it is possible that the maximum dimension might vary.
Okay.
I have not assessed the size, sir, here.
Okay. And any patient required another surgery for cosmetic purpose or only
Yes,
one
sir.
surgery?
So the ptosis patients, there were 8 patients who developed ptosis because the LPS is also sometimes manipulated in the process because the fibers of LPS are often attached to the tumor. So they had to undergo the ptosis correction surgeries. That were 8 cases.
Hi Rolika, great presentation. So I was curious to know that 3 approaches were used for these tumors:
Yes.
transconjunctival, anterior orbitotomy, and lateral orbitotomy. So how was the complication profile different between these 3 approaches? I saw
Right.
one patient you mentioned to have total vision loss post-surgery.
Right.
What was the approach for that particular patient?
Yes, ma'am. Ma'am, the patient who had total vision loss was the one with the optic nerve involvement of the tumor. So it was already known to the patient beforehand only that since it was a like posterior presentation, the tumor was present posteriorly and attached to the optic nerve. That is where the vision loss occurred. The variable presentations that were there were based on the site of the tumor. The ones which were more approachable, they were taken out by anterior approach, but we had to go for a deep cut and a bone cut in lateral orbitotomy for the ones which were posterior. Inferior approach was used for the ones which were in the inferior quadrant, and therefore we could get good cosmesis in those cases.
Yeah, so how was the complication profile different?
Complication profile, ma'am, mostly in the lateral orbitotomy patients, wherein the like as I mentioned that the LPS was attached. There we got the ptosis for sure because the LPS fibers were attached diffusely. So when we are manipulating and dissecting it off, we saw ptosis patients there. The ones with the visual outcome, as I explained, diplopia was seen in one case where it was an anterior orbitotomy, but the patient had medial rectus involvement. That is where the diplopia occurred. So it was not based on the surgical process, approach, but it was more on the site and the involvement of the adjacent structures.
Okay, thank you, Rolika.